Okay, here is your question. There's just one more slide. Once you've read, you can tell me.
Yes, ma'am. Next slide, please.
Yes, here. All right, so if you've read and understood, considering a critical care scenario, please tell me how would you manage this patient? I'll go back so that you can look at the figures.
Yeah. I will manage the patient according to the CRR guideline and start from the airway breathing circulation. And
Yes.
first, I will take the full taking and physical examination.
Okay.
Yeah,
Then,
yeah. I will keep the patient in the ICU for the management.
okay. Can you please tell me how would you take care of our blood pressure?
Yeah, her blood pressure is in the hypovolemic shock and heavy tachycardia. So I will give in the IV fluid challenge. Start with the 5 ml fluid challenge. It's not response within the 20 within the 30 minutes. I will prepare for the blood transfusion.
Okay. Can you please tell me the patient has raised serum amylase? What is the significance of knowing this blood test?
The serum amyloid risk is indicated there will be possible causes of the acute pancreatitis. Serum amyloid not actually serum amyloid not specific for the acute appendix.
All right, good. Considering the scenario of this patient, what are your provisional and differential diagnoses according to which you will be managing this patient?
According to the case scenario, my provisional diagnosis is the acute pancreatitis, and my differential diagnosis are acute cholecystitis, acute cholangitis, possibly myocardial infarct.
All right, good. So how would you confirm your diagnosis?
To confirm my diagnosis, I will take the full clinical examination and history taking and clinical examination. I will do the basic laboratory test like the full blood count, serum, full
Yes.
blood count, liver function test, renal function test, urinary creatinine,
Okay.
ECG,
Right.
ultrasound, atomic.
Thank you. In order to establish your provisional diagnosis as acute pancreatitis, there are certain criteria that you follow. Can you name few?
Yeah, the one of the model Glasgow criteria, Branson criteria, and Apache 2 criteria.
Can you tell me something about Glasgow criteria?
Glasgow criteria contain the PaO2 level, which more than 8 kilopascal, H
Less
more than
than.
50,
Yes.
less than, sorry,
Yes.
which less than 8 kilopascal, H more than 55, neutrophil
Yes.
more than 1,500, now 15,000, sorry,
15,000.
KCN less than 2 millimole per liter.
Okay.
After the 48 hour, read urea level more than 60 millimole per liter. The ADA level more than
Okay.
600.
All right. Thank you so much. Considering this Ranson criteria after admission, how would that be, or how would you interpret that if I ask you to consider the situation of the patient and tell me after admission?
After admission, after 48 hours, I would like to measure the PaO2. If the PaO2 less than 66 millimeter, 8 kilo kPa, KCN level less than 2 millimole per liter, and urea level more than 1.9 millimole per liter, beta phase more than 4 millimole per liter, hemoglobin drop more than Draw 10% or greater.
All right. Can you please tell me
Yeah.
what would be the shock condition of this patient?
And the shock condition of the patient may be septic shock or the hypovolemic shock due to hemorrhagic pancreatitis.
Okay, why this patient is tachypneic?
In the patient, the patient may have is technically due to the abdominal pain and complication of the abdominal pain due to sympathetic overactivity and maybe due to the complication like the acute respiratory distress syndrome.
All right. Can you please tell me if you fail to manage this patient on time, what are the complications that you should keep in your mind?
And complications are the early complication may be the acute respiratory distress syndrome, SIRS, systemic inflammatory response syndrome, multi-organ dysfunction. The complication may be pancreatic acid, pancreatic cirrhosis, hemorrhagic pancreatitis.
Yes. Right. How would you take care of the nutrition of the patient?
I would like to do the central. I would like to insert the central venous line and I will get the total parenteral nutrition.
Total parenteral nutrition. Okay. How long would you consider giving total parenteral nutrition?
For 48 hours
Until?
until the patient has a patient sign and symptom of the acute pancreatitis release.
Would you or would you not consider giving antibiotics to this patient?
And if there is sign and symptom of infection, I would, according to the local trap policy, I would like to get the antibiotic.
Yes, very good. Can you please tell me how would you take care of the pain management for this particular patient as she's complaining of pain?
I will manage according to the WHO pain standard. That start with the
Very good. Yes, please tell.
Starting with the non-opioid like paracetamol, and if patient pain normally, I will increase to the start that into the weak opioid like the codeine, and if not really, then strong opioid like the patidine. Will give via the patient control analgesia mode or epidural analgesia.
What are the benefits and disadvantages of giving patient control analgesia, PCA?
The advantage of the patient PCA is patient is pain totally pain-free to reduce the systemic response. The disadvantage is the overdose in some cases.
All right. What is one test that you'll do and you'll realize that this could be the provisional case of pseudocyst?
I will do the ultrasound domain or MRI, CD domain.
And?
MRI, fluid cytology.
Serum amylase.
Okay.
If serum amylase is raised, how would you conclude that this is pseudocyst and not acute pancreatitis? Bell has gone. So this is my last question. I want you to think about it and discuss it.
If the serum amylase stay in I would like to do the ultrasound domain, CD domain.
Okay. What would you see on ultrasound?
There was a local fluid collection around the pancreas.
Anything else?
And that is conversion of the CVD and conversion of the gastric outlet, maybe.
Something more simpler that you can rule out just by talking to the patient, or what are the components of pseudocyst? Like, how would you know that patient can have pseudocyst?
Pseudocyst is the component of pseudocyst are the amylase rich fluid enclosed in the walls of the fibrous of granulation tissue. There is a no truth. This is the no truth and no true epithelial lining.
Yes, and that is located in the lesser sac.
Lesser sac, yeah.
Yes. Now the more important thing is that the patient would have a symptom of more than 4 weeks, like time period has elapsed, right? So if patient is complaining continuously of epigastric pain from last 4 weeks for approximate a month, a longer history, see? So you can just diagnose it by talking to the patient when patient is giving you a longer period of history, that continuously I was having pain on and off, it became better, then it became worse, and then you do the blood test, serum amylase will be raised. If you do the ultrasound, you'll see the accumulation. You'll realize, okay, near the lesser sac, there is accumulation. So most likely this is pseudocyst, not acute pancreatitis, right? Maybe then you do not need to waste money on CT scan. You can maybe do another test, CEA and and CEA 125 tumor marker. So with that, you could just get to know. So yes, good. Thank you. Any comment you want to do on the labs and the patient chart that you're looking at?
I cannot see very clear.
It's not clear. Yes, I'm sorry. But some dots, this is C, blood pressure and heart rate. You could see here. And if this is the oxygen saturation, I'm telling you 100% or something. And then these are the scores. Anyway, it's two, yes.
But in the Japanese school is the pain score.
Pain score?
It's maximum is 3. The pain score is quite low, I think. Yeah.
Pain score is quite low.
Yeah.
Where exactly is pain score mentioned?
In the schedule, yeah.
Okay.
The pain score, I think the maximum is, I saw 3.
Oh, yes. 1, 2, 3. Yes. Doesn't have to belong to this patient. Maybe.
Oh, yeah.
3. Oh, okay. Come over here. Look. Mild is 1. Moderate is 2. And 3 is severe pain. Have a look at this. So you were just focusing there. You didn't read it here. 3 is severe pain.
I did that. I usually enumerate the base score like the 1 to 10.
No, you have to read the chart carefully, like a drill. And that's the weight of the patient, 65. But 65 doesn't come under BMI 40. Just
40,
suppose if, does this have to do anything with the patient's diagnosis? Like this is a female, 40 plus, and is giving history of a large BMI. So pain cause, a cause of pancreatitis could be gallstones. That kind of scenario, it is being created. Get it? So yeah. So that's the role of BMI. Good. Thank you.
Thank you, ma'am.